Imagine a 150-pound skier, right? They lose their balance on a steep incline, fall hard, and all of that body weight crashes down directly onto an outstretched thumb.
Oh, brutal.
Yeah, and it's unfortunately hooked inside the tough nylon strap of a ski pole. The amount of mechanical force ripping through that tiny joint at the base of the hand is just, it's absolutely catastrophic.
Right. Bones shatter, ligaments tear, and yet,
And yet somehow, the thumb is notorious among plastic surgeons for being incredibly forgiving. So why does a joint that takes so much abuse manage to hide its injuries so well?
well, that's exactly what we're getting into today.
Welcome to today's deep dive. We are running a rapid-fire revision session for those of you preparing for your boards, specifically aiming to crush the FRCS in plastic surgery.
Absolutely. We're going to equip you with the precise mechanisms, the strict classifications, and the exact management protocols for traumatic thumb injuries.
But before we jump in, just a quick piece of housekeeping. Press follow right now so you don't miss future revision sessions. And if you learned something valuable today, please rate this deep dive.
Yeah, it really helps out.
Also, if you want to take your board prep to the next level, get a premium subscription. That gets you exclusive access to our journal club and our clinical cases deep dives.
Which, honestly, are mandatory listening for the exam.
Exactly. All right, so as plastic surgeons, we look at the hand and we know the thumb operates under a completely different set of rules than the rest of the digits. But let's clarify that concept of it being forgiving. What makes the thumb able to mask a serious traumatic injury?
Well, I mean, the foundational rule here is biomechanical. The thumb joints possess a significantly greater range of motion compared to the interphalangeal or MCP joints of the other digit.
Right.
And that extensive mobility means the thumb inherently compensates for minor deformities, things that would be functionally devastating elsewhere.
Like in an index or a middle finger, right?
Yeah.
If a fracture in a lesser digit heals with even like a slight rotational malunion.
The functional deficit is immediate.
Yeah.
The fingers will literally scissor over each other when the patient tries to make a fist.
Oh, wow. Yeah.
But the thumb's extreme adaptability, its ability to rotate, abduct, adduct, flex across such wide planes, it essentially just swallows those minor anatomical imperfections.
I see. So the patient simply adjusts their grip slightly and the deficit goes unnoticed.
Exactly. The thumb is basically hiding the damage through compensation.
Okay, let's unpack this, because that means when a patient actually presents with a thumb injury that requires surgical intervention, we are dealing with forces that have completely outstripped that massive compensatory ability, right?
Right. It takes a very specific high-velocity mechanism to do that.
And that brings us to the first major, highly tested eponym on the boards, Bennett's fracture.
Oh, classic.
Yeah, but I see this term thrown around in the emergency department constantly. A junior resident will look at a film, see, any crack at the base of the first metacarpal, and automatically just label it a Bennett's.
Yeah, and examiners love to catch candidates falling into that lazy habit of loose terminology.
So what is the strict board-testable definition?
A Bennett's fracture is not a catch-all term. The strict definition is a fracture subluxation of the first carpometacarpal joint, or CMCJ.
Fracture subluxation, so two parts.
Exactly. The mandatory criteria are that the articular surface must be involved, resulting in a fractured fragment, and this is key. The joint itself must be subluxating or actively dislocating.
So if both of those elements aren't present.
It is not a Bennett's, simple as that.
Okay, so let's look at the mechanism that causes that specific injury. If it requires such significant force to overcome the thumb's natural forgiveness, it can't just be like a random bump against a door frame.
No, definitely not. The classic mechanism is a severe axial loading force applied to a flexed CMCJ.
Like throwing a punch.
Yeah, exactly. If you picture someone throwing a punch and the fist connects awkwardly so that the force is driven straight down the long axis of the first metacarpal bone.
While that basal joint is bent forward.
Right. That specific vector axial load on a flexed joint is what causes the structural failure at the volar base of the metacarpal.
I really want to break down the anatomy here for the listener, because visualizing the deforming forces is honestly the only way to understand how to fix it. I always picture a Bennett's fracture as a massive three-way tug-of-war happening inside the hand.
But that is a perfect analogy.
Right, because the moment that bone breaks at the articular surface, the structural integrity is just gone. And these powerful muscles and ligaments immediately start ripping the pieces in entirely different directions.
They really do. We have to look at the anatomy in two parts, right? The The small piece that breaks off and the large piece that makes up the rest of the thumb.
Let's start with the small piece.
Okay, so when that axial load fractures the bone, it breaks off a small volar lip fragment, and that specific tiny fragment actually stays perfectly in its normal anatomical position.
Wait, really? It doesn't move at all?
It does not move
Yeah.
because it's anchored to the trapezium by the palmar oblique ligament.
Oh, the beak ligament.
Exactly, frequently referred to as the beak ligament.
Okay, so the beak ligament is acting like an anchor, holding that tiny triangular corner piece exactly where it belongs in the joint socket.
Right.
But the rest of the thumb, I mean the entire metacarpal shaft, is now disconnected from that anchor.
And that is where the deforming forces take over. The entire remainder of the metacarpal shaft is acted upon by two distinct, very powerful muscle groups that no longer have the bony architecture to hold them in check.
Okay, what's the first one?
First, the adductor pollicis, which attaches on the ulnar side, forcefully adducts and supinates the metacarpal shaft.
So it's pulling the thumb tightly inward toward the palm and rotating it outward. That's two forces right there in that one muscle.
Yeah. And then the third force enters the equation, the abductor pollicis longus, or APL.
Okay, inserting at the dorsal base of the metacarpal.
Right. And that exerts a massive pull proximally. It basically yanks the entire shaft upward toward the wrist.
Wow. So the overall picture of your tug of war is the small fragment is locked in the joint by the beak ligament. The massive metacarpal shaft is sliding up toward the wrist because of the APL.
While simultaneously being pulled into the palm and twisted by the adductor pollicis.
Man, if I am the surgeon walking into the trauma bay, I have to systematically defeat every single one of those specific vectors to get the bone back together.
You do.
So if the APL is pulling the bone up toward the wrist, step one has to be longitudinal traction, right?
Yeah.
I physically have to pull the patient's thumb straight out distally to stretch out the APL and get the bone back down to the right length.
Exactly. Step one gets the bone back down to the joint line. But the adductor pollicis is still twisting the bone inward.
So step two.
Step two requires pronation of the metacarpal. You have to physically twist the thumb in the opposite direction to counter the supination force from the adductor.
Got it. I pull it out, I twist it back into alignment, and then what? It's still dislocated from the joint.
Right, so step three is applying direct physical pressure right at the base of the metacarpal. You literally push the base of the bone back down into the joint socket so it lines up with that tiny volar fragment.
The one anchored by the beak ligament.
Exactly. And once you've overcome all three forces, traction, pronation, direct pressure, you hold that reduction by applying a tightly molded below elbow cast.
But casting is conservative management. And we're talking about a joint that is under massive constant tension from the APL and adductor. I mean, those muscles don't just stop pulling because we put a cast on.
No, they don't.
So when does conservative management fail? What is our surgical cutoff to take this to the OR?
You take an x-ray in the cast. If you see persistent instability, meaning the joint continues to subluxate because those deforming forces are overpowering your cast, you must escalate.
Because leaving a subluxated joint basically guarantees post-traumatic arthritis.
Absolutely. The next step in the algorithm is percutaneous K-wire fixation to mechanically lock the bone in place.
For the boards, what are the specific trajectories for those K-wires? We aren't just driving them in blindly, you know?
No, definitely not. There are three standard configurations. First, you can drive the K-wire through the base of the first metacarpal directly into the trapezium, essentially locking the CMCJ so it cannot move.
Okay, and the second?
Second option is transfixion of the first metacarpal base across the web space and into the second metacarpal, using the stable index finger metacarpal as a post.
Right.
And the third option is combining both techniques to create an ultra-rigid construct that totally neutralizes the APL and adductor forces.
Okay, but what if the forces are so extreme, or, I don't know, there's soft tissue caught in the fracture site, that closed reduction is simply impossible? You pull, you twist, you push, and it just will not line up.
Well, an irreducible fracture subluxation is an absolute indication for open reduction and internal fixation, or RF. You open the joint and physically screw the pieces back together.
Right.
But, and this is a major caveat here that examiners use as a trap ORF, is usually not feasible if the volar lip fragment comprises less than 20% of the articular surface.
Because if that fragment is smaller than 20%, it's essentially the size of a pebble. Trying to drive a standard titanium screw through a piece of bone that small is just going to shatter it into dust.
Exactly, which leaves you with an even bigger problem than you started with. So if the fragment is less than 20%, you abandon the idea of rigid plates and screws, and you fall back on K-wires and external support.
Allowing the fracture to heal through secondary intention rather than primary
Yeah,
compression.
precisely.
So we've seen what happens when the base of the bone breaks into two pieces. But here's where it gets really interesting. What if the energy of the trauma is even higher? What happens when that metacarpal base shatters into three distinct pieces?
Right, moving away from Bennett's.
Yeah, straight into another highly tested eponym, the Rolando fracture, which is honestly routinely misunderstood.
Oh, constantly. The Rolando fracture is defined with the same strictness as the Bennett's. It is specifically a three-part intra-articular fracture of the base of the first metacarpal.
Okay.
On an X-ray, the fracture lines typically form a distinct Y or T shape right through the base of the bone.
And this is another area where the terminology gets abused, right?
Uh,
People see a completely pulverized metacarpal base, just a bag of bone gravel, and they call it a Rolando.
yeah, the term is routinely misused to describe all comminuted fractures of the first metacarpal base. But a true Rolando is purely that three-part intra-articular pattern. It implies a very specific geometry that dictates a very specific surgical plan.
So why does that exact distinction dictate our surgical plan? We established that the thumb is forgiving. If a true Rolando fracture is just broken into three pieces, why not cast it?
It comes down to the joint cartilage. Non-operative treatment simply cannot effectively reduce and hold the articular surface in a three-part fracture. The deforming forces will shift those pieces.
And if it heals badly.
If the fracture heals with a step-off, meaning the cartilage surface is no longer perfectly smooth but has a ridge or a drop-off, it acts like a pothole in a road.
Ouch.
Yeah. Every time the patient moves their thumb, the opposing bone grinds against that step-off, leading to rapid, debilitating arthritis and a major weight-bearing joint of the hand. You are forced to surgically restore the smooth joint line.
Right. And the standard approach for restoring that smooth joint line in a true Rolando is an ORF utilizing a T-plate. We go in through either a dorsal or a radiopulmar incision, piece the three fragments back together like a puzzle, and lay a titanium T-shaped plate across the base to buttress the bone.
Exactly. Compress it into a single functional unit.
But let's go back to that misdiagnosis we talked about.
Yeah.
What happens when the surgeon opens the imaging and it's not a neat three-piece Y shape? What if the base is highly comminuted, like 4, 5, or 6 pieces?
Well, you hit a structural wall with standard internal fixation. In highly comminuted Rolando-type fractures, you simply don't have enough intact bone stock to hold the screws.
Because if you try to put a T-plate on bone gravel, the screws will just pull right out.
Right. So in those severe cases, the backup plan is external fixation.
I really want to visualize this for the listener, because the concept of external fixation sounds counterintuitive, you know. We have a shattered bone inside the hand, but we're putting a metal frame outside the hand to fix it. How does an external frame actually align the bone fragments deep inside the thumb?
It utilizes a biomechanical principle called ligamentotaxis. You place pins into the intact metacarpal shaft distally and into the trapezium or radius proximally and connect them with an external bar.
Okay.
By extending that bar, you apply longitudinal tension across the joint. The joint capsule and all the surrounding ligaments are still attached to those tiny shattered bone fragments.
Ah, I see.
So when you stretch the joint capsule tight, it acts like a rigid mold. The tension on the soft tissues physically squeezes the bone fragments back toward their anatomical alignment.
While simultaneously preventing the metacarpal shaft from collapsing proximally toward the wrist.
Exactly.
It's like pulling a drawstring bag tight. The tension on the outside fabric forces everything inside to cluster together in the center.
That's a great way to put it.
But before we even get to the OR to apply that X-fix, there's a diagnostic trap, right?
Yeah.
How do we accurately assess how many pieces the bone's actually broken into?
Well, standard plain X-rays notoriously underestimate the degree of comminution at the first metacarpal base. The anatomy is complex, the bones overlap, and a 2D film simply cannot capture the true damage.
So you might look at an AP and lateral film, think you have a manageable 3-part Rolando fracture, prep your T-plate, and then open the patient only to find unfixable bone gravel.
Which is a nightmare. To prevent that, surgeons routinely utilize a CT scan. The CT provides a three-dimensional map of the fracture lines and fragment sizes, dictating whether you prep for a plate or an external fixator.
Okay, so we've covered what happens when the bones shatter under pressure. But sometimes the bones are structurally dense enough to withstand the load, and it's the soft tissues that fail. Moving distally from the bony injuries at the CMCJ base, we hit the soft tissue stabilizers of the metacarpophalangeal joint, the MCPJ.
Right, an area ripe for easily missed injuries and tricky exam questions. Soft tissue injuries are inherently tricky because they don't show up on standard plain films.
So a patient comes in with massive thumb pain, the X-ray is totally clear of fractures, and it's very easy for a junior doctor to send them home with a sprain diagnosis, completely missing a catastrophic ligament rupture.
Exactly. You have to rely entirely on the mechanism of injury and your physical exam.
Let's focus on the most commonly tested soft tissue injury, the ulnar collateral ligament, or UCL, avulsion. The classic scenario is a skier falling onto an outstretched thumb, planting the ski pole, and the strap violently forces the thumb radially, tearing the ligament on the inside of the web space.
Yeah, very common.
The terms skier's thumb and gamekeeper's thumb are constantly interchanged. What's the difference for the boards?
The terminology is distinct and based entirely on acuity. Skier's thumb describes the acute avulsion of the UCL from a sudden, violent, traumatic event.
Okay, and gamekeepers?
Gamekeeper's thumb specifically refers to chronic attenuation of the UCL. It gets its name from Scottish gamekeepers who developed laxity from the repetitive stress of twisting the necks of rabbits over a long period of time.
Wow, okay. Well, missing that acute skier's injury leads to chronic instability and weakness of pinch. They suddenly find they can't turn a key in a door or open a tight jar. So what does this all mean for healing? Like, why wouldn't it heal if we just throw it in a cast? This brings us to the dreaded Steiner lesion. Explain the exact anatomical trap that prevents conservative management here.
The Steiner lesion is a fascinating quirk of local anatomy. The UCL sits deep in the thumb. Lying directly over top of it is a broad, fibrous sheet of connective tissue called the adductor aponeurosis.
Oh, okay.
When the thumb is violently forced outward, the UCL snaps off its insertion point on the proximal phalanx. As it recoils, the free end of the ligament can actually flip outward, catching and displacing dorsal to that adductor aponeurosis.
I'm trying to picture this spatially. It's almost like a curtain blowing violently out an open window during a storm.
Yeah.
The window suddenly slams shut, and the curtain is completely trapped on the outside of the house.
That is the perfect way to visualize it. The torn ligament is the curtain, and the broad sheet of the aponeurosis is the closed window. When the thumb returns to its resting position, the aponeurosis is physically interposed between the torn end of the ligament and the raw bone it needs to attach to.
Wow. And that trapped state is the Steiner lesion.
Yes. And because that dense sheet of tissue is blocking the way, there is absolutely zero chance of spontaneous bony or ligamentous healing. The body cannot bridge a gap through an aponeurosis.
Which means conservative management is physiologically impossible. If a patient has a Steiner lesion and you put them in a thumb spica cast for 6 weeks, the ligament will just scar down to the outside of the aponeurosis.
Exactly. You've wasted 6 weeks, and the patient still requires a complex surgical reconstruction. Diagnosis is everything.
So how do we test for a UCL rupture in the clinic to avoid that?
The diagnostic protocol is highly specific. You must perform stress testing of the UCL by pushing the thumb radially to see if the joint opens up. However, you cannot perform this test with the thumb completely straight. You must test it with the MCPJ flex to exactly 30 degrees.
Wait, why does the angle matter? If the ligament is torn, shouldn't the joint open up regardless of how it's bent?
You'd think so, but if the thumb is in full extension, the volar plate, which is the thick ligament at the front of the joint, and the accessory collateral ligaments are pulled completely taut. They act as secondary stabilizers.
Oh, I see.
So even if the UCL is completely snapped, those tight secondary structures might hold the joint together when you push on it, giving you a false negative. Flexing the joint to 30 degrees introduces slack into the volar plate, entirely isolating the proper ulnar collateral ligament.
Okay, you flex to 30 degrees, isolate the UCL, and apply radial stress. What specific metrics indicate a complete rupture versus a partial tear?
You're always comparing the injured thumb to the patient's healthy contralateral thumb. You're assessing 2 things. First, an angulation difference. If the injured joint opens up more than 15 degrees wider than the healthy side, you suspect a rupture.
And the second thing?
Second, you're feeling for the endpoint. In a healthy ligament or a partial tear, when you push the joint open, it eventually stops firmly. You feel a hard stop.
Right.
If the joint feels mushy or it just continues to open up without a distinct stopping point, a soft end point, that indicates the ligament is completely severed.
Let's translate that exam into management. If the stress test shows a firm endpoint and less than 15 degrees of laxity, We diagnose an incomplete injury. That gets a cast for 4 to 6 weeks, right?
Yeah, managed conservatively.
But what if the exam confirms a complete rupture?
A complete rupture drastically increases the probability that a Steiner lesion has occurred. And since we established that a Steiner lesion will never heal in a cast, a complete rupture dictates surgical repair.
And the standard of care for that repair is to open the joint, locate that avulsed curtain of ligament, pull it back inside the window by freeing it from the aponeurosis, and rigidly reattach it to the bony footprint.
Right, usually reattaching it with a Mitech bone anchor. You drive the small titanium anchor into the bone and use the attached sutures to tie the ligament down.
And then protect the repair for 4 weeks, gradually increasing activity. Well, we have covered a massive amount of high-yield ground today. For everyone preparing for the FRCS, here are your core takeaways.
Let's hear them.
First, master the tug-of-war of deforming forces at the CMCJ. Second, strictly define your eponyms to dictate fixation versus plating. A Bennett's fragment must be larger than 20% to withstand ORF, and a true Rolando dictates a T-plate. And finally, recognize when an interposed aponeurosis demands immediate surgical anchoring.
I want to leave you with the final biomechanical thought experiment to ponder before your exam. When we look at the ultimate recovery of pinch strength, consider how the interplay between restoring the rigid bony articular anatomy in a severe Rolando fracture compares to restoring the precise soft tissue ligamentous tension after a Steiner lesion. How do these different tissues dictate the ultimate functional outcome of the thumb?
That level of synthesis is exactly what examiners are looking for. Think about that as you review your notes today. I want to hear your thoughts or any questions you have on today's material, so drop down below the track right now and leave a comment. Keep pushing, keep studying, and we will see you on the next deep dive.